Anyway, good morning, and you are all very welcome to this morning's event. My name is Eddie Cassidy, and I'm chairman of the Irish Lung Fibrosis Association, which is generally known as ILFA. Today we hold our first virtual patient information day of 2023, and we have a morning planned with a fantastic lineup of guest speakers. We are very grateful to all our speakers for their time and expertise, and I hope you will enjoy their presentations. As always, with virtual technology, we hope everything will run smoothly from here on in, and we are very grateful to have Justin helping us here this morning. The order of speakers this morning is Professor Killian Hurley, Dr. Roisin Cahalan, Dr. Anne-Marie Russell, and Jess Mandizha. We will then take a short break, and we will be resuming with Donna Langan, Grace O'Sullivan, and Jerry Fitzgerald. So without further ado, I will introduce our first speaker, which is Professor Killian Hurley. Professor Killian Hurley is a consultant respiratory physician with specialist interests in pulmonary fibrosis who works at Beaumont Hospital and the Royal College of Surgeons, Ireland. Professor Hurley is chair of the Interstitial Lung Disease Group at the Irish Thoracic Society and is also a great friend to ILFA. Professor Hurley's presentation is entitled Idiopathic Pulmonary Fibrosis. So with that, I would be over to yourself, Professor.
Great. Good morning, everybody. Delighted to be here, and thank you very much for the invite. I was reminded I gave my first talk to ILFA back in 2018, another in 19. So I really enjoy these presentations and getting your questions and talking about pulmonary fibrosis of all types. But today I'm going to specifically talk about idiopathic pulmonary fibrosis, and I'm very happy to take some questions at the end if you want to put them through the chat. Right, so really breaking it down. So pulmonary fibrosis is scarring, so scarring of the lungs. And when it's in the setting when we can't find another cause, we call it idiopathic pulmonary fibrosis. And if you can see that little diagram of the lungs there, when you look right down at the very, very small, minuscule microscopic level where the air is exchanged, the disease happens there. Back in these little bubbles, what we call the alveoli, where the oxygen is exchanged. There is many other types of fibrosis from other causes, such as exposures to dust, chemicals, autoimmune diseases. Most common one would be rheumatoid arthritis, radiation, and some medications can rarely cause fibrosis. So what causes IPF? So really the honest answer is we don't really know. And that's why they call it idiopathic, I guess. But there are some theories. Some people think about it as early aging of the lungs, or that the repair of the lungs after an injury isn't working right, and it leads to accelerated scarring. But the result is that the lungs at these small little areas, as I was just describing, these little bubbles where the air is exchanged into the blood, they could become fibrosed and scarred. And this results in the lungs becoming stiff. And often it's compared to an air bellows, where the air is trying to get out, but it's restricted. And this causes a difficulty with breathing and also difficulty taking up the oxygen into the blood system. And this is what leads to difficulty for patients walking and the shortness of breath that patients complain of, and sometimes the cough. So what are the signs? Just mentioned shortness of breath, and often people can have shortness of breath for up to 6 to 12 months before their diagnosis of IPF is made. That's very common. So a dry cough, so that means a cough that's not producing anything. Fatigue is common, and weight loss can also be common. And when you're doctor or a nurse listens to your lungs, what do they hear? Well, they hear this Velcro-like, what we call crepitations. The sound sounds like opening Velcro at the bases of your lungs. And when we look at your fingers, we can see this broadening of the digits or the nails called clubbing. And that's present in about half of people that have idiopathic pulmonary fibrosis. So it gives us an indication that might be the cause. So how are people affected? So generally speaking, people are diagnosed with IPF over the age of 60, and it's rare in those less than 50. It's slightly more common in men, in smokers, and those that worked in a dusty environment. And while we don't have very reliable numbers, we think that about 400 to 500 people per year are diagnosed with IPF, and that gives us a number between 1,000 and 2,000 people in Ireland who currently have IPF. So it's a big number. So how do we make a diagnosis of idiopathic pulmonary fibrosis? So one of the first things patients will have had, or you will have had, is a chest X-ray. So this is on the left here. Let's see, we call it CXR when we shorten it down. And on your X-ray, it should look, air is black and white signifies tissue or scarring. So you can see at the bases of the lungs here that there's this kind of net-like pattern over the lungs. And I'm going to show you a scan. So this is a high-res CT scan. So you're going to all be experts at reading high-res CT scans after today. So you can see here that the nice lung is replaced at the center, which should be a kind of a gray or black. It's replaced by these net-like pattern, and we call this honeycombing, where the lung is destroyed. I'm just going to cycle through this. And this is not normal, and this is what really gives you the shortness of breath, and also at the cough that we associate with fibrosis. So another part of the investigations is pulmonary function testing and also oxygen assessment. So we look for the capacity of the lungs, so the forced vital capacity. That's how much the lungs, when they're healthy, can they take in terms of air. We also look at what we call the gas transfer, or DLCO, and that's a measure of how efficient your lungs are at exchanging gases. And if that drops below about 80%, that's not normal. So that might be an indication that something's happening in your lungs. We can assess your oxygen saturation in your blood by measuring with a finger probe. And we can do a 6-minute walk test to see if your oxygen also drops when you walk. Because sometimes people's oxygen is fine when they're sitting around, or when they walk or exercise, their oxygen levels drop. Okay, so making the diagnosis of IPF is a little complicated, and it's actually made by a team. So we call this the multidisciplinary meeting, where the team meets. And the goal of this meeting is to make a diagnosis for patients, and we discuss the cases. We'll look at the X-rays and CT scans, and we'll look at a biopsy if it's done. And we'll reach a consensus on the diagnosis, and we'll take the next steps in terms of starting treatment for somebody or referring them on to other specialists. And the teams are big. So this is just an example. This is the team that we have in Beaumont Hospital. So there's myself and a radiologist, a number of radiologists, the clinical nurse specialists, also work with some great rheumatologists who give us advice about those who have rheumatoid or scleroderma or other diseases. If someone needs a biopsy, we'll send them to a thoracic surgeon, usually over in the Mater Hospital, and a pathologist will read it. And if they need some management of their breathlessness or end-of-life care, will involve palliative care. Of course, the key people as well are physiotherapists, who will help us with pulmonary rehabilitation, oxygen, and they work very closely with the nurse in the clinical nurse specialists. So how do we treat IPF? So one of the mainstays of treatment are antifibrotic medications. So there's 2 on the market at the moment, and there's more being developed. So one called pirfenidone and the other called nintedanib. Some patients also get antacids, or what we call proton pump inhibitors, which are like protium or nexium. And that's because sometimes patients have reflux, and reflux can make your fibrosis worse. And some people think it has a part to play in its development of IPF. About the antifibratics, they've been shown to be successful at reducing the decline in the forced vital capacity. So that's what we measure in the pulmonary function. And when we compare them to not getting drug, it seems that it does slow that down in studies. But there can be side effects. Not everyone gets side effects, but the more common side effects are changes to appetite, nausea and vomiting, or diarrhea. It's important to remember that we've tried some things for fibrosis that don't work, including steroids and anti-inflammatories. And while you might get those when you have an exacerbation or be on very low doses, high doses of steroids are not used routinely for a pure idiopathic pulmonary fibrosis anymore. But what are the other treatments? So there's some really important other treatments. So oxygen therapy is extremely important for patients. It allows them to walk further, to exercise, and it tries to stop this inhibition or limitation that they may have from having a low oxygen. Pulmonary rehabilitation is extremely important, and Dr. Roisin Cahalan is going to talk about it later. Exercise and monitoring that exercise is also very important. And here's a picture of Nicola at the top of Kirkpatrick doing some of the things that we would like our patients, if they're able to do, in terms of getting some exercise. Symptom control is a huge part of managing pulmonary fibrosis. And I think Grace O'Sullivan is going to speak a little bit about that as it pertains to the involvement of palliative care and clinical nurse specialists. And when the time is right and for the right patient, transplant referral and assessment is something that can be considered. So a patient-focused pulmonary fibrosis service looks a little like this. So it's patient-centered. So the patient is at the center of all the strategy and thinking about how we treat patients and how we deliver that care. And the goal here is to find the best care for that individual patient and to offer appropriate treatment at the right time to the appropriate doctors or to the appropriate paramedical staff as well. So really important people within the team that takes care of a patient are social workers, speech and language, occupational therapy, dietitian, and psychological care. Not every service has this. In fact, I'll show you some numbers about that across Ireland. But these are the kind of things that we would like to be able to offer patients in a really truly multidisciplinary team. And so what's happening in Ireland at a national level for patients with pulmonary fibrosis? So with the Irish Lung Fibrosis Association, also the Irish Thoracic Society, which represents doctors and other clinicians who work with patients with IPF. We were able to start a IPF registry to try and record the numbers accurately of patients that have IPF across the country. The aim of that is to improve the diagnosis and to improve the equity and delivery of treatment across the country, and to do some studies, including those regarding familial IPF. I'll talk a little bit about that at the end. At the moment, there's 9 specialist centres across Ireland who take care of patients with IPF. So there's a number in Dublin, 1 in Cork, 1 in Limerick, and in Galway, and also 1 in Drogheda. And those specialist centres have a consultant with a specialist interest in IPF and other clinicians and nurses and paramedical staff that can take care of patients with IPF. Clinical trials are also ongoing at some of those centres where new drugs for IPF are being tested with patients with IPF. In 2018, the Irish Thoracic Society was able to produce a position statement, which is available on their website. And this outlines what patients should be receiving ideally at a specialist centre and what kind of care they should expect. And the Irish Lung Fibrosis Association, before that, was able to develop a patient charter detailing what patients should expect in terms of their care. So what services are patients currently receiving? So ILFA ran a very successful World Cafe Day back in 2021. And during that and afterwards, they did a survey of lung fibrosis patients and also of those post-transplant patients. This is conducted in July and August in 2021. The responses were collected online, and it was a very successful. It was 112 responses. And what it showed in terms of what kind of care, in terms of outside of the clinician, what are patients receiving? So most patients, but not all, so 58% have a clinical nurse specialist, 38% only have a physio, only a quarter have dietitian, and very small numbers have access through that service to social work, occupational therapy, palliative care, and speech and language. So there's a lot of work to be done. This is probably can be delivered through a national care pathway for pulmonary fibrosis, which both the ITS and ILFA are pushing for at a national level with the HSE and Department of Health. So what research is now being carried out for patients with IPF in Ireland? So I'll just go through some of those things. So we think that familial pulmonary fibrosis is common in Ireland. So that's fibrosis that occurs in more than one person in a family. And we think that's suggested by the numbers that are through this Irish Thoracic Society IPF registry. So about 1 in 5 people that have IPF also have another family member, either first degree or second degree relative with fibrosis. And we are interested in Beaumont and also in the Royal College of Surgeons in discovering why. We're also interested in understanding, do we have different genes in Ireland? So we know about genes in other countries, but are there other genes in Ireland that cause or contribute to pulmonary fibrosis? And we also want to know, do people that have a family history of fibrosis, do they have a more progressive or more aggressive form of fibrosis than what we call sporadic? So that means in patients that don't have a family history. So to that end, we saw it and were successful in getting funding from the Health Researchers Board, so HRB, to do the Precise PF study. So that's just a study of families in Ireland, and that's ongoing, just starting to recruit patients. So we've probably recruited about a quarter of the patients that we aim to. And so that really sets out to try and set up a national referral pathway for patients that have a family history of fibrosis that would be centered in Beaumont Hospital and RCSI. Try and estimate how many people have familial fibrosis in Ireland and what types of genes are common. And we have collaborators across the country in all the hospital groups, and we also partner with our collaborators in Paris who have got a lot of experience in looking at the genes that are important in IPF. And so that's the research. And if you're interested in that research, please do contact me and reach out. I'll leave an email and some other contact details at the end of the talk. So just to wrap up with a final slide. So idiopathic pulmonary fibrosis is a progressive scarring disease of the lungs. We know a lot about it, but we don't really understand the causes as yet. There's new treatments and they offer hope of slowing the disease down. But really important to remember that non-drug treatments are as important. They include rehabilitation, exercise, and also staying positive. Focused and organized care by teams, such as we've described, so this multidisciplinary teams, are really important to help people cope with symptoms and the disease. And more research is needed and is ongoing in Ireland. And we're very happy for people to be involved in research, which I think is an important part of finding new treatments and cure for IPF. So at this time, I'd like to thank you. And if there's questions, I'm very happy to take those.
Thank you, Killian, for a wonderful talk. Our next speaker, excuse me, is Dr. Roisin Cahalan, lecturer in Respiratory and Cardiovascular Physiotherapy in the School of Allied Health in the Faculty of Education and Health Sciences. ILFA was delighted to work with Dr. Cahalan and her colleague Ciara Mead over the last few years, delivering virtual singing for lung fibrosis patients. Dr. Cahalan's presentation is called Benefits of Exercise, Singing with Lung Health for Lung Fibrosis. To you, Dr. Cahalan, I hand over now. Thank you.
Thank you, Eddie. Justin, you might load up the slides there if you don't mind at your own time. And thank you very much to Gemma and Nicola and everybody at ILFA for having me again to speak to you. I suppose I'll keep talking anyway, but as you all know, exercise is so important. There we go.
There we go. There we go.
There you go. Okay, so you're all, I suppose, quite well informed about the benefits of exercise. So we know that it improves our general heart health, that it gives us energy, which might surprise some people because the last thing you want to do when you don't feel particularly energetic is exercise, but it does actually improve our energy. It improves our strength. It's really important for mood and for stress management, which obviously is a key challenge with conditions like ILF. It can give you a great sense of accomplishment to be able to achieve something that is difficult and challenging for you. It aids sleep, and this is a key thing because for all of us at any stage, when sleep is poor, everything else in our lives tends to be harder and more difficult. So sleep and optimizing your sleep and having good sleep is really important, and exercise can help that. It helps weight control, which is really important, and confidence and quality of life generally. And that's all fantastic, and it's very easy for me to say. But what we do know is that there are barriers to exercise. Some of these can be time. Some of these can be fear. So I'll talk about that in a sec. Some of this can be access. So trying to get access to the type of exercise that you want to do, the equipment that you might need, the setting that you might need, depending on your location, the facilities that are around you, and so on. Fatigue, just being so bone tired or so depressed or so down on yourself that exercise is really the last thing on your mind. And that can be a real challenge for people. And exercise capacity. So if you feel really weak, really breathless, if your cough is really problematic or troublesome, it can be hard to know where to start sometimes. And that can just leave you a little bit of a loss about how do I actually start exercising? What can I do? How do I get on the road? And then interest, you know, it's when you have a condition like this, there's so many things that you have to do and so many things that you shouldn't do and you can't do. And it's very hard to balance all of these things and to do something that you really may not have any interest in, and finding the part of exercise that you really like and that doesn't feel like exercise, if that makes sense, that's really important. So are we moving on there?
Yep.
There we go. So Killian spoke about pulmonary rehabilitation, and outside of the medical, the pharmaceutical management, it really is very important in terms of giving you all the tools that you need to try and manage the condition. So in addition to exercise, which I'll speak about, it gives you advice about general lifestyle management and psychological support, ideally, and all those other elements that are so important in dealing with a holistic condition and a condition that affects every part of your life, like fibrosis can do. With pulmonary rehabilitation, there are barriers, we know, in Ireland in terms of access and places that are available and referral. But I think that really is changing. We're seeing, in my neck of the woods anyway, down here in the Midwest, there are a lot more classes available, and there's a new pilot project coming up soon where GPs will be able to refer people to pulmonary rehabilitation. And if I could advise people to be your own advocate for this, if you think this is something that you need, really talk to your GP, talk to your healthcare practitioner, if that's your nurse or your consultant, about getting on this program, because it really is, there's loads of evidence to support how good this program can be. And we see all the benefits of it. And one of the things, I suppose, with exercise that can be a challenge also, though, is just managing your shortness of breath. So if we have shortness of breath and we exercise, it'll make us more short of breath. And that's what it's meant to do. But for people who are pathologically short of breath, or for whom it is really scary and challenging, it's not a state that you want to put yourself into. So what can happen is we get into a vicious cycle of being very short of breath, not exercising, and as such we become less fit, you know, we become weaker, we become more impaired in our day-to-day lives. And that has a vicious circle in terms of even easier tasks become more problematic, and we get short of breath easier and easier and easier. So it's really important to understand that shortness of breath is part of exercise. And it's good because it means that we're challenging our muscles that help us breathe. We're challenging the muscles of our arms and legs. And so long as it's done safely and in a way that you feel comfortable, it's something that you should embrace and just go, okay, this is going to make me a bit stronger so that something that was hard this week mightn't be so hard in a couple of weeks down the line. So there's some practical advice I can give you around that. And the first thing really is to work with your medical practitioner, your partner, whoever you're dealing with, in terms of maybe setting those goals around exercise. You know, what's safe for you to do, what's not safe for you to do, and setting SMART goals. So SMART goals is something that we talk to our patients, our students about all the time in terms of setting goals for patients. And it means, you know, SMART stands for specific, measurable, achievable, realistic, and timely. But basically what this means is set small goals that mean something to you that you think you'll be able to achieve. So if that means I'll be able to walk to the shop, you know, twice a week, and it'll only take me 10 minutes and I'll be able to rest just once on the way, or I'll be able to play with the grandkids, or I'll be able to walk up and down the stairs without getting very, very short of breath after exercising for a couple of weeks. And setting SMART goals is really important because it gives you something to aim for. It gives you a sense of achievement when you get there. And it's something to build on. And the thing with goals is, you know, they're not set in stone. If something is too easy, you can set a harder goal. If something is too hard, you can adjust it to make it a little bit easier for yourself. And what I'd say is write these down and refer back to them. Choose something you like, absolutely key. And have a partner if you can. You know, it's like anything. When we watch Operational Transformation or any of these things, if you have someone that'll do it with you, and it doesn't necessarily need to be someone with fibrosis, it can be anybody at all in your life that will support you. Try and be active every day. And we'll talk about the different types of exercise in a sec. And don't let setbacks get you down. You know, we all have bad days. We all have days where it just doesn't happen, the exercise, or we have a bad session for whatever reason. And there's loads of reasons. So, you know, this is a marathon, not a sprint, in terms of exercises for life. So don't let a couple of bad days get you down. Get back on the horse. And then reward yourself when things go well or you achieve your goal, and whatever that might be for yourself, you know. So be good to yourself. And kind of my tips, but I don't have pulmonary fibrosis or idiopathic lung fibrosis. So I've tried to find some advice from people that do. And this was really good for me, good insight from somebody who doesn't have the condition. So the advice from people with ILF would be to alternate the areas of your body that you're exercising with. So don't always use your arms day after day. So use your arms one leg, maybe one day, maybe look at balance the next day, maybe do your legs the next day. And use a pulse oximeter or a little oxygen probe to measure oxygen if you're advised to do so. So again, that's something to talk to your medical practitioner about. For some people, it can become a little bit of an obsession where you really don't need to. So chat to your doctor and see what they think about that. Drink lots of water to help with the cough, as we know can be really bothersome. And alternate positions to maintain your energy reserve. So don't always be exercising in the same position. Distract yourself. And I'm a big fan of this one in my own exercise. So I'll put something on TV or music while I'm doing my exercise. So if you're on the bike or something, maybe you'll put on, you know, a podcast, or you'll watch some television, or even read the newspaper if you can manage it. So the exercise gets done, and it's not too much of an imposition or too boring. Practically then, there's 4 types of exercise that you really should be alternating. And these are flexibility, your strength, your balance, and your endurance, or your cardiovascular exercise. And it's really important that we address these 4 types of exercise because they all do different things. Sorry, move on there. So flexibility, especially for people who have lung conditions, we tend to get quite tight up around our shoulders, our shoulder girdle and our neck. So making sure that you stretch everything out. And it also helps when we try to do a big breath in and so on. And just general exercise then to just make sure that the big body parts, the arms and the legs, stay flexible. And that will improve your general mobility overall. Balance is key because as Hurley was saying that, you know, this tends to affect older adults, and we also would be at risk for falls in this area. So working with your practitioner to look at balance in terms of your lower limb balance to make sure that falls don't become an issue for you. And the great thing about balance exercises is once you do them safely in a safe environment, you can't really tire yourself out, and you do see improvements relatively quickly. So that's something that I think is sometimes forgotten, but it's really important for our general well-being and quality of life. And then I suppose the big ones then would be really your endurance and your strength. We're not moving on there. There we go. So there's lots of different of ways to strengthen and to stay fit and cardiovascularly fit. So with strengthening, I'd say think about the big muscle groups, so your arms and your legs, and make sure you talk to your doctor if you have things like osteoporosis in terms of ways you should and shouldn't bend. But just in terms of building muscle will help your overall health in terms of staying fit, strong, preventing fractures, all that kind of stuff. So it's really, really important. So get those weights out, or those cans of beans, or those bottles of water, or whatever it is. And you can do lots of body weight exercises that you don't need any equipment for at all, but it is important. And then, of course, cardiovascular exercise, walking, cycling, dancing, whatever floats your boat, that's what you need to do. So something that you enjoy, and try and push yourself so that you are that little bit out of breath, so that it's not just a stroll in the park. You know, it's exercise. We want to be getting a benefit from it. So those are the four main types. And to just ensure that you take the advice in terms of alternating them, setting goals, and progressing as you can, and always linking in with your medical professional if you're not sure, whoever that might be. So the next thing I want to talk about briefly is Sing Strong. So some of you might have been involved in the program, and it's a singing program for people with all sorts of lung conditions. And it's really that anyone can join. And we have, in addition to the singing classes, which work on building your respiratory muscles, we have talks from a range of clinicians. So physios and GPs, dietitians, social workers, psychologists, whoever our members want to come in, that's who we get in. And we've been running this for quite a while, and with Fibrosis Ireland as well, or ILFA Ireland as well. So it's been really successful. We do it online, and we're getting back in person as well, which has been fantastic now that COVID is finally settling down. Fingers crossed. Hope I haven't jinxed anything. So we'll move on. So just in terms of Sing Strong, doesn't matter if you can't sing or you've never sung. It doesn't matter if you're mobile or on oxygen. Anybody can join in. Doesn't matter if you're broke, because it's free. It doesn't matter if you can't attend the classes, because we record all of them and we'll send them out to you. And the more that you can do, actually, the better that the benefit you'll get. If you're good with computers and you're doing the online classes, we can help you with that. If you hate exercise, it doesn't matter, because this never feels like exercise, and that's why it works, and that's why it gets done. And if you're up for a bit of fun with people like you, well, this might be the way that you can get involved in exercise. So just in terms of the benefits, I won't go through this. It's a bit lingo kind of heavy, but basically singing, all sorts of singing can improve mental health, quality of life. It can improve your immune function, increases your sense of happiness. And for this type of singing that we do, which specifically focuses on your lung health, it actually can increase or improve the performance of your muscles of respiration. And it's equivalent to a brisk walk. So it's when you get out there and you do your singing, it's like you've been up and out for a brisk walk. So it has real physiological impact. And we've done a little bit of exercise on this, or research possibly on this. Can I move on there? So there's a bunch of trials that we've done, and they've all kind of shown that it is effective, it works well, and that people tend to love it. So the one I'll focus on is the study that we did in your population. And we did that with Dr. Anne-Marie Russell, who you're going to hear from next in Exeter. And basically we found, you can move on. There, I'll go back one. That we used a bunch of questionnaires. We did it during COVID, so we were a bit limited in what we could do. But the St. George's Respiratory Questionnaire, which is kind of a global questionnaire for lots of people who have lots of different conditions, we found some improvements. But when we looked at the specific ILF questionnaire, we did find significant improvements in kind of breathlessness, disease impact, and small improvements in how people felt generally and the urgency of coughing. But I think most importantly, it helped people gain mastery over their condition and found that they could control some of the problems of their condition better. and also that they really enjoyed it. So 4.7 out of 5 will take that. And most participants, 14 out of 15, were happy to do more sessions of Sing Strong. So we are continuing to roll that out with ILFA. So in terms of what people have said, you know, this is really representative of the feedback we get all the time. Found it really helpful, better in myself, helped me physically and mentally, very helpful with our own exercise programs, and a huge impact on well-being. So for any of you who are interested, I'd say to contact us, and we're more than happy for people to join our regular groups, or if the ILFA group starts again, but we have online groups all the time for people with lung conditions. So basically that's my presentation. I'm sorry, I'm a little bit rushed, I have to fly off, but I just want to say to people, you know, exercise is key. It's really, really important, and it doesn't have to be a chore. So find what you love and build it up gradually. And if you have any questions at all, you can contact me either at info@singstrong there, or at my UL address that I'll pass on to Gemma and Nicola. And thank you again to ILFA for having me involved. It's a wonderful organisation, and it's great to have that patient representation for you guys across the country. Okay, thank you.
That's wonderful, Roisin. I know that you're in a hurry, so thankfully you got off the hook. There's no outstanding questions, and I know Killian has been answering some personal questions from some patients online there as well. So thank you so much, Roisin. I'll hand back over to Eddie for our next speaker.
Lovely. Thank you, Dr. Roisin. Very, very interesting indeed. Our next talk will involve a joint presentation. Dr. Anne-Marie Russell is a senior lecturer at the University of Exeter Medical School, and she will be joined by her colleague Jess Mandizha, who is a clinical nurse specialist in ILD at the Royal Devon University Hospital's NHS Trust. Dr. Russell is a long-time friend and supporter of ILFA, and it's always a pleasure to work with Anne-Marie. So with that, I will hand over to Dr. Russell, Support Self-Management in ILD. Thank you.
Okay, lovely. Thank you, Eddie, for that introduction, and thank you very much to ILFA for giving us the opportunity to talk about some of the work that we've been doing. And it's always a pleasure to be at a patient information day. So we're going to talk today. I'll give a little bit of context and background to some of our work in supportive self-management, and then I will hand over to the lovely Jess Mandizha, who will present some results of a qualitative study, which is really important in respect of understanding patient experience. So really important to think about how we work together collaboratively as patients and clinicians. And Professor Hurley has alluded to what we would expect in a service of excellence that would provide the care that people need who are living with pulmonary fibrosis. And measuring what matters is important to us because some of the metrics help with business planning to help to ensure that those health services continue and that we're meeting the needs of our population. And so I guess we've all noticed that there's been a global pandemic, which has influenced and changed our approach to care. And particularly influenced the way that we're monitoring as well. And so we'll speak a little bit to that and talk about biomarkers such as the forced vital capacity that we use in home spirometry, and how it's really important to think about patient-centered concepts as well when we're planning our services. Oh, sorry, I've got some recording on that. In the UK, slightly different approach to health, and we have the NHS long-term plan that aims to ensure that personalised care is the norm. And when we talk about self-management, it shouldn't be that people are self-managing. It should be that they're supported and empowered to self-manage. So it's about a package of care. It's not just about a device. And so on the back of COVID and with Digital Health England, which is the healthcare system that we work in, we have to think about how we're going to empower people to live well with conditions such as interstitial lung disease. So things have changed and progressed a lot, and I was driving this morning and listening to Radio 4, and there was a reflection on, some of you will remember Blue Peter from the 1970s, and they revisited conversations that children had had about what the world would look like in 20 years' time. And so I guess our blue sky thinking of today is very much the reality of tomorrow, in the pace that we're living life at the minute, and the rates that in some regards things change, but in other ways things are slow in terms of infrastructure to catch up. And I'm here with a lovely patient of mine, Gordon, who's sadly no longer with us, but he was such an inspiration and a pioneer working with us on the early work we did with home spirometry using a very simple device, a Care Fusion device that wasn't digitalized. And this was only back in 2014, so it's not such a long time ago. But of course, we've seen spirometers evolve over time. Something simple like a stethoscope has also evolved, and we're doing a piece of work looking at a digital stethoscope called a stethoscope, which people can listen to the lung sounds through a tiny device, and that can be transmitted to us. And so using our mobile phones, we're able to monitor patients much more, or the opportunity to monitor much more closely for us as clinicians, but also for you as individuals, has expanded. And as Dr. Cahalan mentioned, the importance of exercise. Again, ILFA have done some pioneering work in pulmonary rehab that is available online. And just that visual interaction helps to guide and ensure that pulmonary rehabilitation and approaches can be individualized. So from that early work we did in 2014, looking at home spirometry, a lovely colleague, PhD student of mine, Malik Al-Thobiani, is based at University College London, wrote a very nice systematic literature review and included 13 studies in this review that looked at home monitoring of physiology and symptoms to detect exacerbations and progression in interstitial lung disease. And he found that there was very good correlation between home and hospital spirometry, which is important when we're comparing the two. And all these studies indicated that home spirometry was feasible. And whilst there was some variability in that, people who were invited to participate in research studies were very committed to doing so. And I think it's important to acknowledge that research can't happen without your input and participation. And a lot of the time it requires altruism on your part. So we're exceedingly grateful to work in partnership. And so these are some of the major studies, and I'd like to pay tribute to work that Patient Empower have done. I think Dr. Colin Edwards is on the call, but Empower, working with ILFA, have done a lot of the early pioneering work in with your help as well, looking at the value of longitudinal home spirometry. And other work has been going on in Canada and in Holland as well, increasingly in the US, which complements our early findings. And the reason we looked at home spirometry initially was that it was used for people post-lung transplantation as an early indicator of rejection. And so we were really interested to see if a decline in forced vital capacity on a home spirometry reading could indicate an early exacerbation. And we found that it can. I guess managing an exacerbation is still a challenge, but at least if we're identifying it early, it opens up some opportunities to find better treatment and management, whether that's pharmacological or non-pharmacological. And so I guess we as clinicians got very frustrated in health services with the pace that technology worked. And one positive of the COVID-19 pandemic was that it moved us on a pace, and we were able to embrace new ways of working very, very quickly. And as Professor Hurley pointed out, a lot of people with interstitial lung disease are generally a little bit older and often on medication, either antifibrotic medication or immunosuppressive therapy. And so that was a challenge during the pandemic. And we found that in terms of research, it's had an impact in terms of missing clinical visits. So we have to also look at new ways of delivering research that enable people to stay at home and participate. And that also opens up research to a wider population rather than just focusing on those who live close to specialist centres. And so there's lots of new and exciting opportunities ahead. And Jess will speak to a piece of work that informed this application that we put into NHSX in England. It was a partnership between Royal Devon University Healthcare Trust and Guy's and St Thomas's Trust in London. And it was to look at a real world population and how we could support them at home to better monitor lung function and oxygen saturation. And this was a partnership with Patient Empower. So patients were able to use the Empower app that many of you will be familiar with. And we also looked at integrating some questionnaire data on symptoms and quality of life. Because a lot of the time it's not only the metrics, but it's capturing how a person is thinking and feeling about their condition and that symptom experience that can really help, particularly in identifying exacerbation. And it also opened up the opportunity to ensure we could deliver more telephone clinics. And that's really important if you're experiencing fatigue or breathlessness. We want you to keep your energy for the important things like singing and not to be wasting that energy on a hospital visit if that's something that we can bring to the home. And we're now looking at integrating this data directly into our patient electronic record, which is called EPIC, so that will enable us to do more real-time monitoring and to be able to get back to patients promptly. And so we've been looking at some of the information that's already published, how often people are able to use home monitoring, and how we can identify the number of exacerbations that we'd be able to manage remotely. And these are factors that help us in terms of business planning to look at integrating digital devices into part of routine care moving forward. And of course, our business partners are always interested in cost savings as well. So these are some of the metrics that we've been held to account for to justify the cost of looking at these digital approaches. And we hopefully we're looking at the data that we've got now, and we're starting to analyze that. And I think one of the things we're finding is that switching over to a supported self-management program might not necessarily always be less expensive. It might be in the short term be more expensive, but the important thing to think about is the quality of care as well and the patient experience. So that is something else that we're looking at. We also undertook a survey of electronic devices, and we were surprised actually in a real world population in the UK, and some of you on the call may have completed that survey as well, that the majority of people were using either a blood pressure monitor or a saturation device rather than using a home spirometer. The people who were choosing to use a home spirometer that wasn't part of a healthcare program was in fact quite small, and a lot of people hadn't been given support around how to interpret the readings or how to manage a fluctuation in readings. And that again is helping us to form another piece of work that we're planning. But I guess looking back, I remember in the 90s when people started to use home blood pressure monitors, we were a little bit suspect about putting people in charge of health. And again, it's just a reflection on how much we have moved on and how quickly. And so from that survey, looking at the experience of people using digital devices, the majority of people who answered that survey had a diagnosis of idiopathic pulmonary fibrosis. And the things that people found important about collecting these metrics was that it was empowering and reassuring. It was often a confirmation of how people were feeling. And it enabled people to feel supported within their self-management. But there are mixed challenges that remain, and there's a paper published in the Lancet recently by Marlies Wiesenbeck, and that is a sort of sums up what we've been thinking really, and what's influencing our work is that different digital devices are probably relevant at different stages of the disease course. And that really the choice of digital devices very much needs to be personalised to the individual context, and thinking about how we enable people to monitor safely on pharmacological treatments, but also off pharmacological treatments to ensure that activity and exercise is safe as well. So I'm just going to hand over to Jessica Mandizha now, who will talk to that with a little bit more depth.
So hi everyone, it's really nice to be here, and thanks Eddie for the introduction. So I'm Jess, I'm a clinical nurse specialist based in Exeter, and what I'd really like to share with you is a piece of work that we've just finished actually on capturing patient experience of using home spirometry. So in terms of the background, we know that forced vital capacity is an accepted clinical marker of disease progression in ILD, and home monitoring opportunities have increased, and that's been accelerated by COVID, where access to healthcare has been more limited. And I'm sure that plenty of you on the call today are already using home spirometers. So what we know, and what Anne-Marie has already alluded to, is that we know that using home spirometers, we know that it's feasible, we know it can be done. We know that it's acceptable, that patients will use home spirometry devices, and we know now that the results can be reliable, obviously with some support. But the patient experience hasn't actually been reported yet. There's nothing in the literature that has significantly looked at what it's like really for patients to have home spirometers. And this is obviously really important as healthcare workers. We want to benefit patients, and we certainly don't want to harm them. And it's really important to capture the patient experience in order to understand the impact of what we're doing as we move towards using more technology. So we designed a project capturing some qualitative data, and we recruited patients in our centre in Exeter that were undertaking home spirometry as part of routine care. And we asked them if they would be happy to undertake some additional interviews. 10 patients consented to those interviews. And here are the demographics. So it's a really wide age range, patients in their 50s up to patients in their 80s. Most patients had IPF, but not all of them. And we performed some semi-structured interviews over 4 time points over the course of 6 months. And then we transcribed those interviews, and we analysed some common themes, which I'm going to share with you now. So in terms of the results, patients talked about the anticipated benefits. Obviously, they were undertaking home spirometry in the hope that it would improve their care or their life in some way. And a lot of those anticipated benefits overlapped with what clinicians would hope for too by using this technology. So it might have been identifying change. So that's monitoring more closely whether there's been a deterioration, an exacerbation, something that needs additional treatment. It might be wanting to see whether patients are responding to steroids, for example. So identifying change was really key. and triggering action. So that could be a change in treatment, but patients were also really keen to trigger conversations with their healthcare workers as well, and almost having the data to validate that contact with their team. And interestingly, patients also talked about wanting to understand their condition more thoroughly. So wanting more information about exactly what was going on without having to wait for follow-up appointments. And that was really important. Another key theme was patient needs, which is obviously really important to understand. And these are the themes that came up when we looked at the data. So patients' ownership was really important to patients. So patients wanted to possess, to use, to share their own information. And that might involve keeping a diary or putting data onto a spreadsheet. Yeah, having it to share with other clinicians, so maybe their primary care clinicians, but that was really key. And a lot of patients spoke about frustrations in getting results when they went in for their sort of routine pulmonary function tests at hospital. So that cropped up. Patients needed, obviously, understanding. They needed to understand the data that was being presented. And that was very specific to the patients. So some patients wanted more detail than others. And when we started the project, patients had some training, they had some written information, but it was clear that that wasn't quite hitting the spot. So there's more work to be done on that. And which we hope to address in further work as well. Patients wanted feedback, which is completely understandable. But the level of the feedback that was required varied from patient to patient. But the important thing that came up was that patients wanted feedback even when their results were stable. So even when we would look at the results as clinicians and think, nothing to see here, patients really wanted to hear from their clinicians. And that was really important. And that's linked with that clinical oversight. So the idea that we can give out devices, send people on their way, say, let us know if you've got any problems, it doesn't hit the spot. So patients really wanted to know that the data was being reviewed. That was really important to them. Another need that came up was a need for data. And that was really kind of reflected in, it was often related to patients' professional backgrounds. So we had some engineers and some scientists who would say, I want data, I want as much information about my lung health as I can possibly get. And that was very, very important to them. And then this other need that cropped up was difficult to define, but it was a need to know, to say, give it to me straight, what's going on with my lungs? Even if it's bad news, I need to know. And that was very, very important. So there's some patient quotes here just to illustrate that. So it's this idea that we can monitor trends more closely. And it's this idea about understanding patients understanding their condition more thoroughly. So it's a way of keeping in touch. This is this idea of ownership. So printing off the PDFs, like they want that information. And the need to understand the results, which is also something that came up in another study, which was a survey of patients on their preferences around spirometry, hospital-based spirometry. And it's this need to understand it fully enough to be able to compare to other results and really know thoroughly what's going on. Another key theme was difficulties with home spirometry, and they were as you would expect. So there were some technical issues in terms of downloading apps, connecting via Bluetooth, some issues with technique. So that's making sure that the blows are repeatable, for example, and the physical effort. There were some changes over the time point. So we were interviewing patients over 6 months. And what we found with the technical issues that they reduced over time, as you might expect. The technique, the issues sort of peaked at 1 month, where patients were sort of really learning the technique that they needed, and then issues tailed off again. The issues with physical effort really continued all the way through the 6 months. For some patients, it was the cough that was bothering them. For some patients, it was fatigue, and some patients felt dizzy as well. So it was that was really sort of an ongoing issue. What was interesting at the end of the study was that more patients were making reference to the fact that they were avoiding using it when they weren't feeling well. So when they were, they might have a cold or something like that, and they were avoiding the spirometer. And that really prompted us to think about when we contact our patients, and actually when they stop using the devices, that's the point at which we need to be getting in touch saying, how are you getting on? So that was really important in practical terms. And then patients also spoke about how easy they found the home spirometer. So they found it very simple to set up, maintaining it, washing it, that was all very straightforward. And a lot of patients really did appreciate the convenience. So they're not having to worry about attending the hospital, parking, waiting, and the stress that goes with that, especially when you're breathless. So that was really important to them. And there's some more quotes from patients about that. I'll let you read those. And then finally, the other really significant theme that came up was the emotional impact of using home spirometry. And that's not something that's covered in the literature at all, and is obviously really important in terms of quality of life. So worry came up consistently all the way through the 6 months. So patients were concerned about seeing declining results. They were concerned when results weren't reflected in their symptoms. So, you know, my results were a little bit worse, but I'm feeling okay. What does that mean? And for some patients, it was really triggering. So even looking at the spirometry box was enough to kind of send them into a sort of a cascade of anxiety. So that was really a really important finding. On the other hand, for some patients, the results were very reassuring, and they were glad to see, to have that extra information, glad to see their trends. And sometimes that was even if it was going down, it was helpful for them to know. As you'd imagine, some patients had sort of conflicting feelings around it. There was a bit of, I want to know, I don't want to know, which is completely understandable. For some, it was a reminder of their health issues, and that wasn't helpful for them. And some patients reduced the amount of times that they were performing spirometry. So they were initially doing it every week, and then they would reduce it to 2 weekly or monthly, just because that it was triggering for them. And some patients were completely neutral. It's neither here nor there. It's part of my routine. I'll just do it, and suggested that there was no sort of significant emotional impact for them at all, which just shows that it's going to have to be a very individualized decision when we choose, and when patients choose to undertake home spirometry in this way. There's some very powerful quotes about the emotional impact, which I'll let you read. So again, it's just this underlining the importance that it's an individualized decision, and it has to be revisited. So some patients coped very well initially, and then at the end of the 6 months, actually, it was clear that it was causing them a lot of stress. So it's important in terms of consenting patients initially and having a discussion around this, but it's also important to revisit it. So that's it in terms of the findings. And in terms of the next steps, we've got our paper out to peer review. It's obviously really important to get this data out there, so clinicians can use this when making decisions with patients around home spirometry. We want to share it as widely as we can. We need to optimize our own home monitoring service in Exeter. And obviously what came out of the data was the need to be really cautious when we consent patients, making sure that they understand the limitations as well as the potential benefits of home spirometry, establish that they understand the results as fully as they would like to, and make sure that they really understand the feedback mechanisms, who's going to be speaking to them, how often are we looking at the data, and how can patients get help if they need it. That's all obviously really, really important. We're planning some further research. We're in the process of writing a grant for RFPB, which is Research for Patient Benefit. We are planning to collaborate with ILFA, which we're really excited about. And what we would like to do is we'd like to recruit a larger number of patients because we really want to get as full a range of perspectives as we can. We want to look at other devices. So in the survey that Anne-Marie referenced, it's clear that that patients are using pulse oximeters, and I'm sure that lots of you are using them already. So we want to know about that, and possibly pedometers to measure activity levels. We want longer term data. So as we all know, fibrosis is a chronic disease, and you could have to be using these devices for months and months and years. So we really need to understand over a longer period of time how the relationship changes with those devices. We want to include the experiences of family, because another thing that came out of our data is that it's actually quite hard. It was quite hard for some patients' family members to hear them struggling to perform home spirometry, and that was an issue. So we want to understand that better. And we also want to get the perspectives of healthcare workers, because it is quite a radically different way to work. And we really need to understand the implications of that. Yeah, and that's it. That's what I would like to share. So thank you for listening to us both. Any thoughts or questions?
Thank you for that, guys. But both of you. We'll just leave your contact details. Well, we can share them afterwards as well. You got off the hook. I think there's no questions that's outstanding. I know Professor Hurley has been answering a lot of individual questions from different patients throughout the webinar. So if there's any questions, even personal like that, you can put them into the Q&A box. They're only seen by the panel here on screen. So I shall pass over to Eddie. I believe it's a comfort break time, Eddie.
That's correct. And we're going to have a small comfort break now of approximately 5 minutes. And after that, we will progress with part 2 of our event. Welcome back, everybody. Our next speaker is Donna Langan. And Donna is an advanced respiratory nurse practitioner at Galway University Hospital. And her presentation is called Role of the ILD Nurse. So with that, I'll hand over to you, Donna.
Lovely. So I suppose ILFA kindly asked me to do the role of the ILD nurse. So where my experience comes from, I've worked with Professor Roisin and Helen, one of our advanced nurse practitioners, for the last 10 years in Galway in ILD. So we set up a service in ILD because we've seen, I suppose, there was a need for it. And this is where a lot of our experiences come from, but it also has shown us where we need to improve as well. So I'll kind of cover all those little bits in the next about 20 minutes. So I suppose where we're looking for here is, this is from the ILFA National Patient Charter. So this kind of highlights about 6 points. So early and accurate diagnosis with an MDT input, clear and concise information in plain language, access to the appropriate medicines and oxygen therapy, early referral to pulmonary rehab and exercise programs, early referral to the National Palliative Care Transplant, National Lung Transplant Unit for assessment, and also access to social and practical and emotional supports. So I suppose where we start off is where, when a person comes into clinic for the first time, oftentimes we will get it is that they would be a referral letter from a GP or a referral letter from another speciality. So when the letter comes to our service, our biggest thing is to make sure that we can have all the information. So it may be a case that we need to get previous scans from other hospitals, or a lung function result, or maybe even bloods, or even a background of other conditions. So that's what we're trying to do. An awful lot of the work is actually gathering all this information together. Now, that might not seem like it's a big task, but to make sure your first appointment is the best appointment for you, that's actually critical for us. So as we said, it comes two types of appointments. The first pathway is the patient attends, and there may be a presentation of symptoms. Normally, as Professor Hurley said, it's cough, shortness of breath, weight loss. And if there's no tests done, this time we would start organising bloods, breathing tests, any CT scans to be done. The second pathway would often be the patient will come with a diagnosis, and they're looking for more either specialist team-based approach to their condition, or they may be looking for a second opinion, that the patient already has a diagnosis, but they actually want to make sure that it actually is the most accurate diagnosis for them. So once the appointment has been done, then their case goes to the multidisciplinary team meeting. So the previous speakers have already outlined what the MDT comprises of, but I suppose what is our job within the team? So our job really is, once these referrals come in, it's to make sure that all the information is there. So when the team discusses the case, that we have your background, we know what underlying conditions you have. Have you been already started an antifibrotic treatment and maybe it didn't suit you? Have you been already exposed to maybe some other medications that might have triggered your fibrotic disease? So this is really important, because once we discuss your case as a team, that way we have all the information, and once a decision has been made, that we can actually go forward and give you that diagnosis. So it is quite individualized in each case, so it's really important for us to have all the information so we can give it to you accurately. So delivering the diagnosis, so once the MDT has discussed your case, it's actually to actually deliver this diagnosis. So the person is brought into clinic, they're given diagnosis and their treatment options. So our role really as a nurse is to sit with the patient, their family, we talk through what the diagnosis may potentially mean for them. So I'll go to the next slide, it's actually probably next. So this is what we actually sit down and we see on a day-to-day basis. So this is the path of acceptance. So this is actually devised by Elizabeth Kubler-Ross, which was palliative care consultant. But her thing was that she actually had only 5 steps, but this has actually been revised to 7 steps. So once we give a diagnosis, it's actually the shock for some people. So they may not have been expecting a diagnosis. They may have been just expecting, oh yeah, you have an underlying chest infection, we're going to give you antibiotics and that's it. So for a lot of us, when we actually go and tell them that you actually have an interstitial lung disease, you may not know what that is. And when you don't know what it is, then we have to actually sit down and what that potentially would mean for you in the future. What we get an awful lot of patients is the denial, and that's a very important part of any acceptance process. So it's the kind of, well, why do I have it and my neighbour down the road doesn't have it? But why did I get this when I've done everything right? It cannot be this, it needs to be another condition. That's quite common, and that's we get that a lot at the time, and we understand completely. And sometimes people come back to us and say, I don't know why I said that, but it is completely part of the acceptance process. The next thing really is anger, and sometimes this can come out of any part of an acceptance of any disease, but we often see it in ILDs, is why me? Why is this progressing the way it is? And this can come at very early stages, or it can come 2 or 3 years into a diagnosis. None of these, even though these are look like step-by-step approach here, this is more a circular process than actually a linear one. So then the bargaining, what if I do this, will I get more time? We had someone recently who came to clinic and he was like, I definitely get about 10 years. And we're like, where'd you come up with 10 years? 10 just seemed like a good number. So that kind of, you have this kind of, if I stop this, I'll do this. Or if I start my exercise, will I get more time? And that's very normal. Depression is then the realization that the disease is the disease process and what is going to happen to me in the future. The testing thing is, I suppose, is okay, and it's nearer the acceptance really, is that, okay, I have what I have, but what can I do to change it? Not change it completely, but as in, what can I do to change the quality of my life at this moment in time? And that's a really important thing, because I suppose if any condition anyone has, is we all have to readjust what we think was going to happen in our futures. So we work towards this testing and find out realistic solutions. For some people, it may be, I loved working in my little man cave at the back of my house, and now I can't get there. What are we going to do? And that's what we would look at it all the time, as in, if that's what you want to do, we need to look at solutions to try and get you there. And as Roisin said earlier on, it's trying to get the goal and going to get realistic steps trying to get into that goal. And acceptance is finally finding the way forward. For some people, acceptance is never really achieved. So that's really important for us as a nurse, as part of the team, is to make sure that if we have not full acceptance, that's okay. Some people think, oh, I need to get to all these stages. You don't. And some people will get to the stage of finding realistic solutions all of the time. And if they find realistic solutions all the time, that is okay. So we will work at any stage of this process, but sometimes it can be very hard for people, and we completely recognize this. So another part, I suppose, of our job is, once we are on the treatment options, so Professor Hurley has already mentioned pirfenidone and nintedanib, the oxygen therapy. So for us, with pirfenidone and nintedanib, it's really to look at the symptoms. So what are the symptoms? What's potential symptoms? And we spend a lot of time, like every nurse in the country, doing this. It's the education. What can happen, when it can happen. And our biggest thing is really, patients are sometimes afraid that I do have the symptoms, but they're going to take me off the treatment. We always look at the symptoms. We try and treat the symptoms. That is the most important thing. We do not try and take anyone off the treatment unless it really is impacting on your quality of life. If you cannot leave the house because you have diarrhea constantly, that isn't quality of life, and that's what we're all aiming to achieve. The oxygen therapy, we would be there with the physiotherapist and we would order the oxygen therapy. But the biggest thing with the oxygen therapy for us as nurses is, we always get phone calls, is, I have a family wedding, my son or daughter's getting married in Killarney or Tipperary or wherever it is, I want to go. or else I have my granddaughter's christening or my communion or confirmation or whatever it is, I want to go. And that is our job really, is to make sure we can achieve those things. It may sound a very small thing to someone, but if you're able to sit there for your son or daughter's wedding, that's amazing, and that's a big thing, and we definitely go with that. Navigation supports is really, really important part of our role, because we don't have actually a social worker attached to our service. In fairness, there's not many around the country that do. We kind of become the social worker of the service as well. So we're looking at assistance and medical cards for patients who don't have any, getting on to public health nurse referrals to try and get a bit of home help, even kind of meals on wheels for some patients is major. And then financial support. Some of our patients may have to give up their job because of their diagnosis. So that's a big deal for a patient and for their family. So what we actually do that is that we would look and see, are you eligible for this? Can you get care? Can someone get carer's allowance? Things like that. And also we'll often refer patients to, if they're having issues with their diagnosis and it's causing a bit of stress and anxiety, we would actually also refer them on to the counselling and primary care. So it's a service that patients with medical cards can receive 8 sessions of counselling. So we would refer them on for that as well. And then we look at ideas for remaining active. Roisin has done beautiful presentations. So pulmonary rehab obviously would be our first port of call, but simple things for patient well-being. It may only be sitting out in the garden. Let's say if a patient loves a garden and they said, oh, I love sitting, like I used to love doing my garden and my bulbs and all the rest of it, now I can't do it. It might be just sitting outside in the fresh air, looking at the bulbs being planted, or having them planted by someone else and you can see them coming up. Other things may be, let's say if someone who, if loneliness is becoming an issue for them, it might be a case of, a men's shed, book clubs, depending on how active I suppose people are. Some people would be very, very active and they say, oh, I want to be a bit more active. And some people, it's just a bit of company. So it's constantly kind of trying to keep our minds open as well to anything we might hear as well that might actually help our patients. So we do phone service as well. So our phone service deals with everything. We do new prescriptions, any of the oxygen issues, organising tests, symptoms that arise with the antifibrotic therapy, and also, I never to put on this slide, but is also we also take phone calls from family carers, because sometimes what happens is the person themselves may not feel that they're deteriorating or they're a little bit low, but it's their loved one, their carer, their best friend, that often will ring us up and say, is there any chance you can ring Michael or John or whoever, and see how they are? Because oftentimes when we do those phone calls and we get on to Michael or John or whoever the person is, then we can actually see that, yeah, we're kind of worried about you, or how are you getting on? And that's when they're beginning to open up to us. So we also get involved with the lung transplant preparation. So lung transplant can be a difficult conversation for a lot of people, particularly if it's at that stage of their disease process. So what we would look at is we get everyone involved when the conversation is about to happen, whether it's been a family or friend. We go through the completion of the referral form as well. And for some of our patients, weight management is a big issue. So we try and get as much of the weight management stuff done. Now, unfortunately, we're going on dietitian referrals for the community, and weight management services as well, which is not in our service, but we have to work with other services in conjunction with us. So encouraging pulmonary rehab and remain active. So I suppose thankfully the ILFA online sessions has been a game changer for our service. And then you're kind of looking at the appointments and to go to the matter and trying to prepare a person who is going for assessment, because I think a lot of times people think, oh, it'll be the same as going for an appointment in their local centre. And unfortunately it's not, because obviously it has to be much more in depth. There's much more questions, and there's much more issues that can arise. There's the psychological assessment. So we kind of have to prep our patients before they go, because sometimes it can get very disheartened coming back from an appointment, but you kind of have to prep them to say, look, this is going to be a little bit harder than your normal appointment. And plus, if a patient lives too far from a centre as well, you kind of have to organise oxygen, where they stay and how long it's going to take them there. So for our patients who are on the Western Seaboard, you may say, look, this is going to take all day. So we need to make sure you have oxygen for all day and things like that. So that can be a little bit tricky, but unfortunately, we don't want anyone to be stuck in halfway to Dublin and can't get there. So it's important for us, may not be as important for anyone who lives a little bit closer to Dublin. So I suppose progression of disease is a big thing then, is when the patient comes into us. Some will say that they'll notice a slight progression and some don't. So I suppose if they notice a slight progression, we're always going what the symptom is. Is the case that, you know, we were able to walk 1 kilometre last month and now we're not able to do that? And sometimes when you go back and look at the symptoms, then what happened in the last month? You may have gotten a cold, you may have gotten COVID, you may have had the flu. So things like that, we might be able to work back towards. Or it may be a case that someone comes in and says, I feel fine, but once we've done the lung function test or done another CT scan, we've seen a slight progression with it. So that's really important to us, really, is to highlight the progression to the person as well. And you don't want to be negatively kind of, oh, that's a little bit worse. But I suppose it's, for some people, they like to know exactly where we are on the journey, and other people, they don't want to know the ins and outs, but they'd like to know more vaguely where we're going. It's important to really outrule any of the symptoms that they may be causing. So often we have patients come with shortness of breath, and we'd always look for a cardiac echo, so it's an ultrasound of your heart. And the important thing is that just in case it is anything heart related, that we may be able to work with their cardiology consultants to help improve those symptoms for the person. So these are three documents that through the Irish Hospice Foundation. They're thinking ahead discussions. So while palliative care is mentioned and should be started early on into a person's treatment plan, it's very hard for some patients. But the minute you mention palliative care, they think it's actually a very negative connotation. So what we try and do is we try and engage it from patient to patient. So these are three documents. They're downloadable on the Irish Hospice Foundation, but they're nice documents, especially my personal wishes and care plan. If it's a case that you want to kind of start putting a few thoughts down, and it's a nice one to kind of start a conversation maybe within a family. So the person may be coming to the clinic, but they may feel that their family isn't as prepared as they are. So sometimes that booklet is nice, that if they start kind of going through it, that the person kind of sees where they are on their journey as well. And I won't touch too much on this because I know Grace is going to palliative care after me, so I won't go too far ahead of her. So follow-up care for us, it does not stop with the person who's living with the ILD. So often what happens in our service is when the person has died, we will phone the next of kin, see how they're coping with their loss, and then we, depending on the person, we will kind of deem an appropriate time frame for this. Sometimes it's 1 month, sometimes it's 3 months only after the person has died. We always send a sympathy card as well, and every year we would like to get a light on the Christmas tree for the person who's passed away the year before. And we're very happy at any stage that a family member or friend would like to contact us. So we always say that our number doesn't stop with the person, it always stops with, it goes on to their bigger circle, and that's really important to us. So I think I'm going to stop there if that's okay.
Super, thank you for that, Donna. There's been a couple of questions. Hi, Donna. Is there a 6-week counselling service in all areas of Ireland? ILFA gets a lot of calls from newly diagnosed patients that have no support and would really value of a service like this. Is that across Ireland?
Yeah, that's across Ireland, because I actually just looked it up there before we started. So that's across Ireland. So your GP or your healthcare professional can refer you, and it is between the different healthcare numbers across Ireland. So that should be available. I don't know what the time frame is between services, but it's a good one to try anyway. Yeah.
Great, thanks for that.
Yeah.
Just on the basis of time, I'll get
Perfect.
Grace to do her presentation.
Sorry.
Yeah, sorry, Eddie. I should have said over to Eddie.
Yeah, our next speaker is Grace O'Sullivan. And Grace is a respiratory clinical nurse specialist at Cork University Hospital. Grace's presentation is entitled Research on Palliative Care. So I'll hand over to Grace now.
Thanks, Eddie. So I'll just begin to share my screen now. So thanks again to Eddie for the introduction, and thank you to ILFA for inviting me here to talk today. So like Eddie already said, my presentation is going to be on research on palliative care in pulmonary fibrosis. So I'm a respiratory clinical nurse specialist in Cork University Hospital. So just a quick overview. What exactly is pulmonary fibrosis and what are the associated symptoms? What does quality of life actually mean, and what factors may influence it? Why is palliative care important, and what are the current guidelines around the implementation of palliative care in pulmonary fibrosis? What is currently happening in practice? Are there barriers to timely implementation? And where do we go from here? So I know Professor Hurley spoke in greater detail about what pulmonary fibrosis is, but I'll just give a quick recap. So it's a lung condition that causes the lungs to become thickened, stiff and scarred. This is what causes shortness of breath. It's a condition that gets continually worse over time. And it's important to remember that the rate of disease progression is different in everybody. And again, it's important to remember that as I talk about palliative care this morning, to remember that everybody's at a different stage in their disease trajectory. So again, the most common symptoms associated with pulmonary fibrosis are dyspnea, also referred to as shortness of breath, cough, fatigue, and of course there's other physical symptoms such as, gastrointestinal acid reflux, and again, extending beyond the physical symptoms, psychological effects such as depression and anxiety. But dyspnea or shortness of breath can be referred to as episodes of breathing difficulty, and it does have an impact on the ability to carry out activities of daily living. Cough, there's a lot of individuals with pulmonary fibrosis would refer to cough as being exhausting and debilitating, and it can also lead to other issues such as nausea and sleep disruption. Fatigue, also referred to as a lack of energy, and again, individuals would often say they feel exhausted even after a full night's sleep. We know that these physical symptoms have an impact on one's quality of life. So I know quality of life is a term that we hear about a lot, but what exactly is it? And the World Health Organization defines quality of life as an individual's perception of their position in life in the context of the cultural and value systems in which they live, in relation to their goals, expectations, standards, and concerns. And this is, I suppose, quite subjective and very individualized to each individual living with pulmonary fibrosis. Now, there are many factors that influence quality of life. We have spoken a little bit about the physical health and the physical symptoms, but again, quality of life is multidimensional and there's lots of other factors that have an impact. So, such as psychological health, level of independence, personal beliefs, relationship to environment, and social relationships. So far we've spoken about pulmonary fibrosis being a progressive condition. It is associated with physical symptoms, and it also has, it's often, there's other factors such as psychological, social, and spiritual. Therefore, it needs a holistic management, the effective approach and symptom control. For that reason, palliative care has been suggested by both national and international guidelines to effectively manage and, I suppose, aid symptom relief for patients living with pulmonary fibrosis. I've screenshotted some examples here, including the American Thoracic Society documents in 2011 and again updated in 2015, the Irish Thoracic Society position statement, and again the National Patient Charter for Idiopathic Pulmonary Fibrosis by ILFA. So what exactly is palliative care? The World Health Organization defined palliative care as an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illnesses. It identifies, assesses, and treats problems, and not just physical, also psychological, spiritual, and social. It aims to promote dignity and ensure comfort, and overall, I suppose, positively enhance or improve experiences within the healthcare system. One of the very important messages that I'll get everyone to take away from this morning's talk is that palliative care is there in conjunction with other therapies. I think there's been a stigma attached to the term palliative care that it means, giving up, hopelessness, and that's not the case. What these guidelines recommend is that palliative care is given to improve quality of life and to be given in conjunction with other therapies, such as the therapies recommended by your respiratory team. It empowers decision-making, and we want every patient with pulmonary fibrosis at the centre of this decision-making process with members of the multidisciplinary team. It's the inclusion of a family, and they're to provide family support also, to complement prevention, diagnosis and treatment along with the respiratory team, continuity of care. And again, it can be applied by all healthcare workers and healthcare teams at different levels. It's not necessarily to say that it's only or solely the palliative care team that implements this. Absolutely, we get a lot of expertise from that area, but it can be introduced at all levels. So, okay, we have established now at this point that palliative care is, I suppose, the recommended guidelines on pulmonary fibrosis, but does it actually help? How do we know it helps? So there's two examples of studies here I've included and the outcomes of palliative care implementation. So the results were improved symptom burden and greater quality of life. It also reduced emergency department visits and reduced length of hospital stays. But again, it's the collaboration of care with the patient at their centre, deciding and making these decisions with the allied health professionals, your respiratory consultant, advanced nurse practitioner, and CNS to, I suppose, create a pathway or a plan that's suited best to the patient living with pulmonary fibrosis with their family. So what's actually happening in current practice? So I've been another 3 or 4 slides coming up now, and they're just screenshots of different studies and I suppose the percentage of palliative care implementation in pulmonary fibrosis or interstitial lung disease. A study in 2015 showed that there was 13.7% referred to palliative care in a US study. Over a 10-year period again, in 2017, 3.8% referred prior to ICU admissions. 2018, between 2006 and 2012, there was 12.9% referred to palliative care. Again, this is another US study. And out of 828 newly diagnosed individuals with pulmonary fibrosis, 13.9% referred to palliative care. And I know Professor Hurley referred to the World Cafe Day earlier on, and there was 6% referred to palliative care from that research. So at this point, I suppose it's clearly, or it's very evident that palliative care is often underutilized in pulmonary fibrosis. And why is this? And I think every research piece out there shows that it's the stigma attached to the term palliative care. It's a lack of understanding and education of palliative care And that's across the board. It's for patients, family members, and healthcare professionals. It's a misconception that palliative care is associated with death, dying, hospice care, and it's not. You know, it's about living better for longer with a better quality of life, supported by your, you know, medical team, family, and having a greater understanding of it all. So what are the strategies to break down the stigma? It's increase awareness and education. And that's why I'm here to speak with everybody today about what palliative care actually is and to break down that stigma. Now, I completed a study 2 years ago now on IPF and palliative care, and it was a qualitative exploration of nurses' experiences in the delivery of palliative care. Now, I suppose my findings correlate with the underutilisation of palliative care that I've discussed earlier on this morning. But one of the, I suppose, common questions that surfaced during this research is when we ask nurses, when should we implement it? You know, what's the best time? And there's no hard or fast rule because each disease trajectory is so individualised. It's very hard to give, you know, something exact. But all that we recommend is that it's introduced at an earlier stage, is that the decision is made with the patient, family, and the members of the multidisciplinary team. Another concept that was seen as a common theme throughout my research was the concept of hope. And I think it's very important to remember this going forward. We all know that hope is essential at the time of a chronic disease diagnosis, no matter what this chronic disease is. And again, throughout the research, I noticed that healthcare professionals feared that they would, I suppose, create a sense of hopelessness when palliative care is introduced because of the stigma attached to that term. And what we hope going forward is that we can break down this stigma to increase the utilisation of palliative care in pulmonary fibrosis to improve quality of life and symptom burden. And we hope that we can change things going forward with this further research. Thank you. And I'm open to any questions if there are any.
Thank you for that. There was, I think you might have answered the main question that a couple of patients have been asking is how early in the disease progression can you avail of palliative care? Yeah, so again, you know, palliative care, like I said, can be implemented by your respiratory team. And then it can, you know, if at that point that we feel that we can't provide enough symptom relief as what we'd like, we could then refer on to the palliative care expertise team. Now, I don't think, again, there's any hard, fast rule of when we implement or when should we not implement. It's a discussion that needs to be had with your consultant, nurse specialist, advanced nurse practitioner, on when best to implement to ensure symptom comfort and, you know, a good quality of life throughout. That's great, Grace. Thank you so much for your presentation. I'll hand back over to Eddie.
Thank you, Grace. Thank you for your presentation. Our next speaker is Jerry Fitzgerald, and Jerry is from Tipperary. And we are delighted to have Jerry share his story with us here today. So I'll hand over to Jerry now.
Good afternoon. I want to thank you everyone for allowing me the opportunity to speak. And the previous speakers are very informative, and it's most enjoyable to hear all this going on and to know there's so much support out there. I'm a beneficiary of all that care and attention I received along in 2022 November. I'll give you a brief run-up as to how it occurred and why I was deemed necessary for this to happen. I was always subject to kind of chest infections and stuff like that, and yearly or so, and I'd get an antibiotic and steroids and I'd be fine. But in 2018, it got considerably worse and the infection didn't clear. And the doctor suspected that my local GP, who was a great man, suspected I had possibly IPF. He referred me then to Dr. Cassidy in Limerick and his team. And after about 2 months or so, I was diagnosed with pulmonary fibrosis. I had monthly visits or when I was bad into Limerick, and 3 monthly visits if I wasn't feeling so bad. And they would keep a very close eye on me. They prescribed an antifibrotic drug for me, Obev. It's one of the designer drugs to delay the progress of the IPF. I was doing really well on that for about 3 years, and the symptoms were quite mild, but the disease was progressing. And I was doing my 6-minute walk tests in there and physio. And on one of the 6-minute walk tests, I was feeling particularly unwell and I had to stop. And I simply couldn't continue. And I was more surprised myself because I honestly thought I could, up until then, I could do them no bother. My oxygen levels had dropped dramatically. So they put me on oxygen just to get me through that session. And I was prescribed oxygen from then on. I started on lower doses in 2018, and I maybe 3 or 4 liters an hour, but I had to use it all the time. And when walking and doing any kind of exercise, it was a bit of a roller coaster for me because I didn't expect I'd have to do that, but I got used to wearing it and I got used to going out and about with the oxygen. My usage increased dramatically then when I was exercising because I like to walk and I like to do work and I like to be out and about. And that was encouraged by everyone, particularly in Limerick. In August in 2020, I was referred to Dublin, to the Mater Hospital. And they looked at me and they wanted to know the viability of me going for a lung transplant. At this stage, my need for oxygen had increased dramatically. And I was put on liquid oxygen, which is a little device at home that produces oxygen, and you put a knapsack on your back and you wear it all the time. But it gave me great mobility at the same time, and I was able to get out and about, and I was not doing too bad. I was losing weight, however, and they were concerned about that. And after maybe after 3 or 4 months, then I was put on the 2021. I was put on the transplant list, and that was going fine. And my first call up then was in September 2021, and I had 5 call-ups pretty much, and the lung that was prescribed, the lung that was available wasn't suitable for me. And so on the 6th call, on November 2022, I got a left lung. That's a kind of a snapshot of pretty much what happened with me. And I've really never looked back since, and I've enjoyed really good health since I got the lung. I'm active and I'm out and about, and I'm pretty good. Now, in the meantime, that's just a brief snapshot. I had pneumonia while this was going on, and I was referred to Limerick. And in that, when I had pneumonia, I had pneumonia in December 2022, in 2020, and in 2 months later also. And after that, during that time, they discovered a clot in my lung, my left lung, which was the one that was worst of the 2. And they were surprised at that. And they said it was an additional danger to me. And so a very close eye was kept on that. And they kept, Dublin then took up the reins on my care. And they went through all the procedure with me, and the run up to a possible transplant happened in August of 2022, and I was in the Mater Hospital for a week where they do these a whole host of tests. And in those host of tests, they found that I needed a few stents in my heart. I was more than surprised. I didn't think I needed anything like that, but I needed 3 stents. And I didn't realize my heart was in any kind of bad shape, because the dependency on oxygen kind of masked the fact that my heart was a bit iffy. So after getting the stents on the stents, and I felt pretty okay, and I was doing okay. And as I said, I was put on the list. I was on the list for a short while, and I got 5 call-ups. I got 2 in September 2022, in the month of September. And they weren't suitable for me, but they may have been suitable for somebody else. That's how it goes. And I'd stay overnight, and I come home next day. And because in all that, I was treated with incredible kindness and professionalism, and a lot of understanding, as the previous speakers have alluded to. And I was encouraged to keep up the exercises and keep up the physiotherapy, and which I've been doing before and during and after the operation. That's kind of my story, pretty much. I have been very, very lucky, because during the when my lung became available, there was a pandemic that was raging at the time, and in 22, in November 22, it was actually at its peak, and where I was very lucky that there was a bed available for me. But that was just the mechanics of it. So I was very lucky also, in as much as I was physically fairly strong when I went into the operation. So I didn't have to stay too long in ICU. I was only 2 days in ICU, and I was only a fortnight altogether in the hospital. I was in Tomica. And I was back on my feet again in a fortnight, walking around the car park outside my house. I got very strong very, very quickly, thank God. And I haven't looked back since, really. I've had no bad days that I can safely say, even though I got COVID and I had the winter vomiting bug from visits to hospital. But I survived them all, thank God. But I'm forever grateful for the entire journey among immensely kind and professional people. And I'm in constant contact with them. ILFA, the people, indeed your good selves, and the exercises are probably the most beneficial thing of all. It simply cannot emphasize how important they are to do the physical, because your condition goes off you, and your strength leaves you, and you have to really work on that to keep it going. So walking and using your exercise bike and the weights, especially. In doing so, I injured myself a little, so I can't use the weights as much, but I was probably a little too enthusiastic when I came out of the operation. I was feeling so good. So that's kind of my story regarding I know it's kind of a snapshot. I might have missed a few dates, but I'm a little nervous when I'm speaking to you, but you get the idea of what I'm saying.
And you're getting lovely comments, Jerry, coming in on the webinar chat here, with people saying thanks for your honesty and thanks for sharing your experiences as well.
No bother at all. I was a little nervous. I'm usually not now, but I have a bullet point list here, and I seem to have only mumbled through it. But the important thing was just to reflect on it would be when I went to Dr. Cassidy's team, and the physio department in their team was vital. They put me on very strict physio that I would do at home and do with them twice a week. The pandemic stopped all that, so I went online. So I couldn't physically turn up, but any of us couldn't. But it's gone full belt now, and it's actually increased to 3 times a week, the classes, which we gladly participate in. And by and large, it's very positive, the whole experience, because as was suggested there with palliative care, that was mentioned to me also, No, I have to confess, I was a little bit nervous at that, because even though I knew it was a terminal illness, I kind of put it at the back of my mind because I thought that was for other people. But clearly it wasn't. I was very much in that drop zone that I could possibly not come out of this. What I found incredibly encouraging, and I should have said it first rather than last, was my partner here, Philippa, who stood by me throughout the entire procedure and was very, very encouraging, because she has her own issues because she's back in college and she's doing a lot of work herself, and she had a very positive influence on me in keeping going. Never missed an appointment with me, always strives for me. I insist on doing it, but she insists on driving me to and from appointments. I don't know how she makes the time, but she does. And I'm really well looked after. I also, as regards the classes, we have a kind of a friendship between us on the ILFA classes. We all know each other by name, and we have it's a great support group. Even though we might only get to speak for a minute or two to each other, we can kind of see how we're doing. And it's always great to see a new lung recipient coming on, or someone who's about to go over, and we all kind of help each other along. I can't believe how much oxygen I was using now that I see it here. I was on 20 bottles in May 2021, and it wasn't enough. So I must be doing a lot of walking or marathons or something, but Jesus, where did I lose? What was I doing without oxygen? But thank God my oxygen is up to 98% now. I don't have any problem at all. I can walk for 5 miles without a bother. Now, there are challenges, of course, but you when I say not a bother, you will feel to get caught, but like, it's what you expect. And but you keep going. And some days are very good, and some days you feel a bit challenged. But I have a black Alsatian, a black Labrador here with me that goes and brings me along whether I like it or not. And, and we get through the whole thing pretty well. Overall, the experience, lads, was extremely positive for me. Starting first over with my partner here, Pip, my local doctor who referred me to Limerick, the team in Limerick, the referral from the team in Limerick, with particular attention to the physio people in Limerick, who then referred me to Dublin. I met Dr. Michelle Murray and her team, and she assessed me and then put me on a list. And it was, you are told that the list can be a bit bothersome for people because they expect on the first call to be fixed up. You're explained to you that that may not happen, and you become quite accustomed to not being called up and the lung not being suitable. And a lot of people ask me, was I bothered by that? In truth, I wasn't, because I'd been well prepared for that. That was in all run-up, all conversations I had with the team in Dublin, that there's a likelihood the lung won't be for you, but it may be for someone else, or it may not be for anyone, because it's a very comprehensive test on the, as you know, to receive a lung, and it is such a special and wonderful gift to get, and so it's not to be treated lightly. And I do recall coming down after a few call-ups and having tea and sandwiches at Junction 14 in Mayfield on the way home. It was a bit like I didn't know what, it was hard to figure out what was going on. It happened so quickly that you'd be up, the lung wouldn't be suitable. And they'd say, if you want to stay overnight, you can, but I'd like to go home. So we'd find ourselves drinking tea and eating sandwiches at Mayfield at 3 in the morning. and during the pandemic, we couldn't even do that because we had to sit in the car. I realized here I must have been telling lies, because the 6th call up I got the lung. I thought it was the 5th. Now you think I had that kind of I have remembered that, but I have it written down here. It was the 6th call up I got the lung, and I was, as I said, very lucky because it was the middle of the pandemic, and it was a very fraught time. And what amazed me about the people in Dublin, and indeed all professional people, it's such a humbling experience that they take everything in their stride. Nothing phases them, absolutely nothing. no matter what you say to them, they weren't one bit phased. And whatever difficulty you might be having, they deal with it and they tell you what's the best source of action to take. And I was overwhelmed really by the humanity and the humor of it. There's a great practice, there's great fun and all this. It's not doom and gloom by any manner of means. They're very witty people. They've seen it all, like, so, and quite charming. And but you have to do kind of what you're asked to some degree. Exercises, diet, try and get as much rest as you can, and of course avoid the local hostelries, and do exercise, and no more alcohol and no more any of that business. It's a new life, and a good one, and a very good one, let me tell you. So I am so appreciative that I'm able to stand here and talk to you, because it's just really wonderful, really, really fantastic.
Well, Jerry, we really appreciate you spending the time to tell
well,
us.
I hope it sounded a little garbled, but I had a much better intention here at my sheet of paper to give a more I suppose.
That's all. I think you spoke from the heart there, Jerry.
I think so too. Yeah, I have all the dates, but I have so many names here. I couldn't get through them all, but all the various people that I met along the way are quite incredible. You know, the important one immediately, I do recall, after the operation, my oxygen coming up to 99%. And I was able to walk the steps at the Malvern Hospital with the physios, and my oxygen not dropping. It was absolutely wonderful, and no oxygen on my back. It was, I cannot tell you how relieved and how joyous it was. It's quite something. And I haven't stopped talking since. So that's the way of it. So you're great people up there. Keep it up.
Yeah.
Thank you, Jerry.
God bless you all.
Good. Okay, I'll hand you back over to Eddie.
Thanks, Justin. A remarkable man, and a great pleasure hearing from him. And I'm sure there isn't a patient out there that hasn't been uplifted in the last couple of minutes listening to the success story.
Thank you very much.
Anyway, my sincere thanks to all our speakers today for the event that has taken. They have taken their time, their expertise, and kindness. I think it was a fantastic series of talks, as this event usually brings about. Organizing this event takes considerable time and planning, and I would like to extend on behalf of myself and committee and friends and supporters and all that to Gemma O'Dowd and to Anne Griffin for all their hard work and dedication behind the scenes. We're enormously grateful to Justin Dawson for his help in managing the technology to deliver this event online. And this year, ILFA is celebrating our 21st anniversary, and our success to date is due to a hardworking committee who run the charity, and thanks to our loyal and ever so generous fundraisers. ILFA's work and events would, like this, not be possible without their hard efforts. ILFA depends on fundraising and donations, and all support is really appreciated. If you or anybody would like to fundraise for ILFA, please get in touch. Please consider taking part in the ILFA 2000 Step Extra Challenge on Easter Monday, the 10th of April. We are asking everybody to walk 1 extra mile on Easter Monday and make a donation to ILFA. You can contact Gemma or Anne at ILFA for more information. I would also like to ask if you or a family member is a member of a club or a society or a company, please again consider ILFA as a potential charity partner. We will welcome such an opportunity. We hope you enjoyed the Patient Information Day and that you will join us for the next one. Thank you all for being with us. Wishing you a lovely weekend, a happy Easter, and stay safe. Slán.